next speaker is Aphpba from Taiwan, and his topic is hepatic failure determines the outcome after actual corporeal hepatectomy and whole transplantation. Welcome.
Good afternoon, ladies and gentlemen. The following topic is presented by Dr. Wen from Johns Hopkins Hospital in Taiwan. Today, my topic is hepatic failure determines the outcome after extracorporeal hepatic resection and autotransplantation. Hepatectomy is the principal treatment for HCC. However, majority of the patients are poor candidates of hepatic resection, either because of their compromised liver function or the HCCs had typical anatomy, such as tumors at the hilum or at the confluence of hepatic vein. In 1988, Dr. Peach Mayer proposed a solution for critical site liver tumor, and that is extracorporeal hepatic resection and autotransplantation. Take this case for example, we can see a huge tumor occupying almost the right liver. The confluence of the hepatic vein, the confluence of the left hepatic vein and right hepatic vein has been invaded, and the middle hepatic vein has been totally occluded. This patient had a preoperative obstructive jaundice, which was treated with an ERCP and intrabiliary stenting. Preoperative liver volume estimation showed a sufficient graft, so the operation was planned in this way. The patient was sent to the operation room. After the whole liver was removed, partial hepatectomy was executed with QSAR. Intraoperatively, we can see that the tumor invaded the confluence of the hepatic vein, and the middle hepatic vein has been totally occluded by the tumor. The explanted tumor part of the liver was around 2,200 grams, and the graft was around 440 grams. We used a temporary portal-GABA shunt to help the patient pass through the inhepatic period. And after partial hepatectomy was completed, the graft was reimplanted in orthotopic position. 1 month later, we followed an abdominal CT, which showed that the liver was regenerated. So the aim of my presentation is to share the 5 case experiences of HCC with typical anatomy receiving autotransplantation between 2011 and 2012, and we hope to discuss the factors determining the outcome. We totally performed this operation in 5 patients. All were male at the old age from 60 to 75 years old. Preoperative data confirmed these tumors to be huge, critical site HCC. The graft weighed from 367 grams to around 1,000 grams. The blood loss was large and made the patient needs massive blood transfusion during the operation. The operation time was around 8 to 9 hours, and we made every effort to shorten the ischemic time. There were 3 successful cases, alive for 26, 24, and 21 months. However, there were 2 hepatic failures. The 4th case expired 12 days after the operation because of hepatic failure resulting from old age and poor preserved liver parenchymal function. The 5th case received living donor liver transplantation 25 days after the operation because of hepatic failure resulting from right hepatic vein compression, liver congestion, and poor preserved parenchymal liver function. But this patient is still alive for 11 months up to now after living donor liver transplantation. These 2 figures illustrated the process of hepatic failures. The 4th case presented with postoperative hyperbilirubinemia and prolonged PT and expired 12 days after the operation. The other case presented with septic shock and hyperbilirubinemia and received living donor liver transplantation 25 days after the operation. We can see that the preoperative liver volume estimation shows sufficient graft, but the liver still failed because of poor parenchymal function. So, the first discussion, is this risky, complicated, and high morbidity operation justified? According to our experiences, 4 out of 5 cases were still alive after the operation, demonstrating that the satisfactory outcome after the operation. There were 3 successful cases, although 2 of them experienced tumor recurrence 8 months after the operation, and was treated with RFA and TACE respectively. So we identified that autotransplantation is the only method with curative intent for critical site huge HCC. And there are some techniques to be discussed. Unlike the commonly used venous bypass, we use a temporary portal cover shunt to help the patient pass through the hepatic period. A temporary portal cover shunt not only reduces bypass-related complications, but also has been proved to improve hemodynamic status, reduce intraoperative blood transfusion, and preserve renal function. A T-tube is suggested to be routinely placed. A T-tube can help us differentiate postoperative hyperbilirubinemia between biliary anastomosis complications or liver parenchymal dysfunction. And the postoperative color Doppler is suggested for routine flow detection. But why is this operation so risky? If we subgroup post-hepatectomy complications into service complications and functional complications, we can see that autotransplantation caters to all the risks. First of all, a graft inevitably will have a large raw surface. Second, the operation reduces residual liver volume to an extent and causes a lot of blood loss during the operation. And most important of all, this operation requires a complicated transplantation technique. So we can say that this operation is so risky because of the high possibility of post-hepatectomy complications, and the graft has to pass through the ischemic reperfusion injury. In other words, this patient is a donor and he is also a recipient. So we conclude that we report 5 huge HCC in typical anatomy, receiving extracorporeal hepatic resection and autotransplantation. The outcome was satisfactory, and 4 out of 5 H patients survived 11 to 26 months. So autotransplantation is an feasible procedure in selected patients and in experienced transplantation center. However, postoperative hepatic failure is still the largest challenge. Thanks for your attention. Taiwan is nearby and just across the strait, and it is a small but beautiful country. We welcome all of you to be our guests someday. Thank you.
Thank you. Any question in the comments? So, how long time hepatic phase if you without shunt?
You mean the hepatic period without temporary portal cover shunt? Including especially for the co-ischemic time, the average co-ischemic time was around 2 to 3 hours, and this time requires the partial hepatectomy. And we know that extracorporeal hepatic resection is very difficult, especially we are unable to check bleeding. Hemostasis is unable to achieve extracorporeally. So the average and hepatic time for requirement of portal cover shunt is around 2 to 3 hours.
Any question? Thank you.
Okay, we'd like to invite the next speaker, Dr. Jane Boone. And the topic is different prognostic factors